Finals SAQ62 Nutrition. A 45-year-old man with a history of ulcerative colitis and alcohol abuse is admitted to the ICU for inotropic and ventilatory support following a laparotomy to excise a toxic megacolon. His BMI is 18 kg per meter square. A. Why should this patient receive early nutritional support, and what are the clinical benefits? This patient needs early nutritional support due to existing malnourishment evidenced by low BMI, chronic alcohol excess and long-term GI disease associated with malnutrition, catabolic state, poor absorptive capacity, and unlikely to be able to re-establish normal oral feeding within the next 5 days, so supplementation is indicated. Clinical benefits include improved wound healing, improved weaning from ventilator, improved immune function, improved rehabilitation due to maintenance of skeletal muscle strength, reduced ICU length of stay and reduced mortality. B. What is the specific composition of a nutritional regimen for this patient? This patient is at risk of refeeding syndrome due to low BMI, alcohol abuse, acute illness leading to reduced recent oral intake, and toxic megacolon and ulcerative colitis leading to electrolyte imbalance. Water requirement 30 to 35 ml per kg per day, guided by fluid balance, abnormal losses, and cardiac output monitoring. Avoid excessive fluid input in refeeding situation. The following are normal requirements, all of which should be cut to 1/3 for the first 4 to 7 days of nutrition in this patient at risk of refeeding syndrome. 25 to 30 kcal per kg per day. Carbohydrates 50% of intake. Fat 30% of total caloric intake. Protein 15 to 25% of total caloric intake with 1.2 to 2 grams per kg per day, ideal body weight. Electrolytes should be guided by frequent blood testing. Increased quantities are likely to be needed in refeeding syndrome. Sodium 1 to 2 millimole per kg per day. Potassium 1 to 2 millimole per kg per day. Phosphate 0.3 to 0.6. Magnesium 0.2 and calcium 0.3 millimole per kg per day. 14 vitamins are essential in daily diet, which includes vitamin A, B12, C, D, E, K, thiamine, riboflavin, niacin, pyridoxine, pentatonic acid, biotin, folate, and choline. 7 trace elements are essential, which includes chromium, copper, iodine, iron, manganese, selenium, and zinc. ICU dietitian will work within the multidisciplinary team to optimize nutrition of this patient. List the advantages and disadvantages of enteral nutrition. Advantages include low cost, avoidance of line infections and complications of line insertion, reduced risk of stress ulceration, maintenance of gut integrity, absorption, and immune function, reduced risk of hyperglycemia, reduced risk of abnormal liver function, hypertriglyceridemia, metabolic acidosis, electrolyte imbalance, and uremia associated with parenteral feeding. Disadvantages: enteral feed may not be absorbed, therefore leading to malnutrition. There is risk of aspiration and pneumonia. Necrosis and bleeding of nose or small bowel may occur due to erosion by feeding tube. NG tube may increase the risk of sinusitis. Overall, 44.9% pass rate. Additional Q&A. Why is nutritional therapy important in critical illness? Critical illness leads to catabolic stress, SIRS, hypermetabolism, multiple organ dysfunction, infection, and malnutrition. Malnutrition leads to reduced immune function, increased morbidity and mortality. Nutrition therapy aims to provide nutritional therapy consistent with the patient's condition, prevent nutrition deficiencies, avoid complications related to delivering nutrition, and to improve patient outcomes. What is the energy yield of glucose, lipid, and protein? Glucose 3.7 kcal per gram, lipid 9.1 kcal per gram, and protein 4 kcal per gram. Describe how daily energy expenditure in hospitalized patients may be estimated. Options include indirect calorimetry and predictive formulae. Indirect calorimetry is performed with metabolic cuts that measure whole body VO2 and VCO2 at the bedside by measuring the concentrations of oxygen and CO2 in inhaled and exhaled gases. Steady-state measurements are obtained for 15 to 30 minutes to determine REE, which is then multiplied by 1440. The formula for REE is included here. There are more than 200 available predictive formulae to estimate REE. One commonly used formula is REE equals 25 times body weight in kilograms. Correction factors frequently overestimate energy needs and are not currently recommended. Predictive formulae tend to be inaccurate. Optimal calories for critically ill are unclear. Patients with high nutrition risk assessed by Nutric score should receive more calories. What are the recommended nutritional intake for obese patients? If indirect calorimetry is available, measure REE and provide 70% of daily calorie requirement. If indirect calorimetry is not available, use the patient's BMI to determine the daily calorie and protein intake. Daily calorie intake should be 11 to 14 kilocalories per kg actual body weight for a BMI of 30 to 50 and 22 to 25 kilocalories per kg ideal body weight for a BMI of more than 50. Daily protein intake should be 2 grams per kg ideal body weight for BMI 30 to 40 and 2.5 grams per kg ideal body weight for BMI more than 40. Which dietary fatty acid is essential? Linoleic acid, for example, from safflower oil. Deficiency leads to scaly dermatopathy, cardiac dysfunction, and increased rate of infection. How much energy does propofol provide, and how does propofol influence nutrition support? For 10% lipid emulsion, propofol provides 1.1 kcal per meal. Calories received from propofol should be taken into account in relation to the overall caloric prescription to avoid overfeeding. Propofol can also cause hypertriglyceridemia, which can lead to acute pancreatitis. Hence, serum triglyceride levels should be measured in patients receiving large doses of propofol. What are the function, risk factors, and consequences of thiamine deficiency? Thiamine functions as a coenzyme for pyruvate dehydrogenase. Risk factors for thiamine deficiency includes alcoholism, hypermetabolism, diuresis, magnesium depletion, and degradation by sulfites. Consequences includes cardiomyopathy, Wernicke's encephalopathy, lactic acidosis, and peripheral neuropathy. Thiamine deficiency can be diagnosed by plasma thiamine measurement or erythrocyte transketolase assay. What are the harms of supplemental iron in ICU patients? This includes increased risk of infection, and iron is a major risk for oxidant cell injury. What are the benefits of selenium in the critically ill? Selenium acts as an antioxidant and lowers mortality in severe sepsis. How should the nutritional status of critically ill patients be assessed? Inaccurate measures include albumin and prealbumin levels and anthropometric measurements. Aspen recommends Nutric score or the NRS score. What mode of feeding should be initiated in critically ill patients? Unless absolute contraindication to enteral nutrition exists, such as ischemic bowel or bowel obstruction, EN should be initiated preferentially over PN. Although meta-analysis shows no differences in survival, compared to PN, EN has lower infection rates, lower cost, reduced gut atrophy and bacterial translocation, and EN supports gut lymphoid tissue. When should EN be initiated in critically ill? Within 48 hours of ICU admission, if no contraindication. Early EN reduces mortality and infection but does not alter the length of stay or mechanical ventilation. When is enteral nutrition contraindicated? These include conditions that lead to non-functioning GI tract, such as ischemic bowel, intestinal obstruction, severe malabsorption, and severe short gut syndrome. In general, pancreatitis, enterocutaneous fistulae, and recent GI surgery are not contraindications to EN. When should PN be initiated in critically ill? Aspen SCCM guidelines recommend that PN be considered in the following two circumstances. After 7 to 10 days of hospitalization in critically ill patients who are not malnourished and who have a lower nutritional risk, but in whom enteral feeding has not been feasible, or who have only received a fraction of goal calories. Second circumstance, on admission in critically ill patients who are malnourished, who have higher nutritional risk, and in whom enteral feeding is not feasible. Compare and contrast nutrients in EN and PN. Nitrogen source in EN includes intact proteins, peptides, or amino acids. Nitrogen source in PN includes amino acids. Carbohydrates in EN include simple and complex carbohydrates, while parenteral nutrition contains simple carbohydrates. Lipids in enteral nutrition include long and medium chain triglycerides or long chain fatty acids. For parenteral nutrition, lipids include linoleic and linolenic acid. Vitamins and minerals are present in enteral nutrition and can be added in parenteral nutrition. What are the major complications associated with EN and PN? Complications of PN includes central line placement complications, metabolic derangements such as hyperglycemia and electrolyte disturbances, increased infection, immune suppression, hepatobiliary dysfunction, gut atrophy, venous thrombosis, and overfeeding. Complications of EN includes GI-related such as vomiting, aspiration, diarrhea, constipation, and ischemic bowel. Mechanical complications includes obstruction of feeding tube, erosion of feeding tube into mucosa, accidental insertion of feeding tube into the lung. Displacement of feeding tube leads to risk of aspiration, pneumothorax, empyema, and bowel perforation. Nasogastric tube increases the risk of sinusitis. Metabolic derangements are less common than with parenteral nutrition. Describe the risk factors and pathophysiology of refeeding syndrome. Risk factors include low BMI, unintentional weight loss, poor recent nutritional intake, hypokalemia, hypomagnesemia, and hypophosphatemia, alcoholism, and drugs such as chemotherapy, insulin, and acids and diuretics. Chronic malnutrition causes depletion of electrolytes through reduced intake and utilization for metabolism. Serum electrolyte levels are maintained better than intracellular levels due to reduced energy for transmembrane pumping and reduced insulin-dependent pumping. Upon refeeding, there is sudden increased insulin-driven uptake of glucose and electrolytes into cells. Serum levels of these ions, such as magnesium, phosphate, calcium, and potassium, can drop precipitously. Cardiac muscle is also weakened by chronic malnutrition. On refeeding, circulating volume increases due to glucose-driven osmolality. This risks heart failure. Weakened respiratory muscles must attempt to cope with increased CO2 production as the body reverts to more carbohydrate-based metabolism. This may precipitate arrhythmias, seizures, respiratory failure, cardiac failure, coma, and death. What are the complications of overfeeding in the critically ill? This includes hyperglycemia, liver compromise, increased CO2 production from lipogenesis, leading to increased ventilatory requirements, and worsened outcomes. How is diarrhea defined and how may it be assessed? Diarrhea is defined as more than 500 mL of stool output per day. Causes of diarrhea includes drugs, infection, osmotic diarrhea, impaction, and other causes such as IBD, pancreatic insufficiency, and short gut syndrome. There are no specific workup for drugs. Discontinue any of these medications that are not absolutely necessary. CD toxin assay, stool culture, and colonoscopy for evidence of pseudomembranes can be used to assess CD infection. Infectious diarrhea can be assessed using fecal culture. Osmotic diarrhea can be assessed by measuring stool osmotic gap. More than 100 suggest osmotic diarrhea. Impaction can be assessed by rectal examination. Treatment of diarrhea includes treatment of underlying cause, stool bulking agents, increased soluble fiber intake, change of enteral formula, and anti-motility agents. Should critically ill patients in shock, which are receiving vasopressors, receive enteral nutrition? EN should be avoided in patients who are in shock, and in patients whom resuscitation is active, vasopressors are increasing to avoid the risk of bowel ischemia. Once the patient is adequately resuscitated, EN may be initiated. Observe for signs of intolerance. Should gastric or small bowel enteral nutrition be used? Small bowel enteral feeding is recommended when possible, as it is associated with a reduction in infections, particularly pneumonia. Should enteral nutrition be delivered continuously or in boluses? One pseudo-randomized study found that aggressive early EN via bolus feeding was harmful. It is generally thought that bolus feeding is less safe than continuous feeding. However, a paucity of evidence is available on this topic. How should EN tolerance be monitored? This includes regular assessment of pain, abdominal distension, stooling and vomiting. New guidelines recommend that gastric residual volumes should no longer be measured, as 3 RCTs demonstrated that checking GRVs provide no clinical benefit. How should critically ill patients be positioned during enteral feeding? Patients should have the head of their beds raised to 30 to 45 degrees. Should motility agents be used in critically ill patients? Motility agents such as erythromycin and metoclopramide is recommended when clinically feasible, especially in patients with signs of enteral feeding intolerance, as these agents improve gastric emptying and tolerance of EN. Enteral naloxone may provide benefits such as increased volume of EN infused, decreased GRVs, and decreased incidence of VAP. Should feeding protocols be used in ICUs? In an effort to start enteral feeding in the critically ill and to provide adequate calories, especially in high nutrition risk patients, feeding protocols should be implemented. This includes early rapid startup of EN, goal infusion rate, and directions for when to stop and start feedings. Should critically ill patients receive pharmaconutrients or specialized feeding formulas? Based on low-quality evidence, antioxidants such as vitamin E and C, and minerals such as selenium, zinc, and copper should be provided to ICU patients, especially those with burns or trauma, and those receiving mechanical ventilation. Parenteral glutamine provides no benefit to critically ill patients and may even be harmful, hence should be avoided. Arginine is recommended for patients with severe trauma or traumatic brain injury and in post-op critically ill. However, avoid arginine in sepsis as it may increase mortality. Use of feeding formulas containing omega-3 fatty acids such as fish oil in patients with acute lung injury and sepsis remains controversial. It is unclear whether specialized formulations are beneficial in ARDS. Patients with AKI should receive early EN and standard amounts of protein and calories. Protein restriction should not be used to delay the initiation of dialysis. Specific enteral formulas designed for renal failure that have varying electrolyte compositions or are calorie dense can be used if needed. Standard formulas are recommended for patients with liver dysfunction. In patients with acute pancreatitis, early EN is now the standard of care. For patients with burns, they should receive 30 to 40 kcal per kg per day, protein of 2 to 2.5 grams per kg per day, and adequate micronutrients and trace elements. Is nutritional therapy obligatory in end-of-life situations? Provision of artificial hydration and nutritional therapy is not obligatory in cases of futile care or end-of-life situations. These are my references. Thank you.